Hi there, this is Amy Fernow. I'm one of the current interns. I'm going to be presenting today on chest pain. I'll also be touching on atrial fibrillation and in regards to tachycardia, that's covered more in Brent Sherwin's lecture on tachycardia and hypertension, so definitely reference that and all the other lectures too. So as I'm thinking about chest pain and what I wanted to present to you all today, I'm thinking mostly of calls you're going to get in the middle of the night on the general surgery service and what you want to do about them. So we're going to be thinking what can kill our patients, what's very dangerous versus what is not dangerous, and what is common. So the differential diagnosis of both preoperative and postoperative chest pain is very broad. And it can include all of these things and more. So it could be musculoskeletal, it could be appropriate post-op chest pain, depending on what operation they've had. It could be related to traumatic injuries. It could be secondary to anxiety. It could be due to GERD. Maybe a home med didn't get restarted and GERD's flaring up. It could be due to oxygenation status, COPD, asthma. It could be due to cold drinks in bariatric patients, since they tend to tolerate room temperature drinks with much more ease. Or it could be due to really dangerous things like aortic dissection or pneumothorax or ischemic heart disease, pulmonary embolism. So these are all things that will be running through your mind when you get that call in the middle of the night that the patient's having chest pain. So what do you do when you get that phone call? What you really want to do is go and see the patient. Know their past history or look up their past history, talk to them in the present, see how they describe their chest pain, look at their vitals, look at their oxygenation status, and then things that are going to be running through your head as you're putting all those pieces of the puzzle together. Or do I want to get an EKG? Do I want to get troponins? Do I want to get a chest x-ray? Maybe a CBC, a BMP, a BNP, electrolytes, an ABG. Doesn't mean you're getting all of these things every time, or maybe any of these things every time, but these are things that are running through your mind. So again, make sure you go and talk to the patient and look and see how they're doing. So let's say you go and you talk to the patient and they point to where their chest pain is and you palpate their chest and the pain is reproducible with palpation. This is a scenario where you have a higher suspicion for musculoskeletal pain. You want to correlate it with their recent surgical history and adjust pain medications as necessary. And of course, in this scenario, you have no other reason to think that they're having anything else, any other reason for their chest pain, and you've sort of thought through all the steps that we're going to talk about. So that's a common thing being common. Another scenario where you may not be getting a lot of laboratory testing is if a patient is young, healthy, maybe has a history of panic disorder or anxiety, and they say, I have surgery tomorrow and I'm really nervous about it. And this happens, I get chest tightness when I get really anxious. And this is, of course, a scenario where we need to have a very low suspicion for any cardiac events. And their vitals need to be very stable. In that case, you may not order anything, or you may just order an EKG if they're a little bit tachycardic, like 100 even, something like that. You want to put all the pieces of the puzzle together, but if you're really convinced that the patient is stable and healthy and maybe they've had a negative cardiac workup recently and you think this is just anxiety, you want to reassure, make sure that they're on their home medications. I'm not a big fan of jumping straight to benzos, so a good thing for sleep to give is melatonin, but you also want to make sure they don't have benzo withdrawal, so definitely make sure to do a good med rec. Another scenario where you really want to look at home meds is if a patient has GERD. So if they say this is how my GERD feels, I just ate, I have reflux, I usually take Protonix at home and I'm not on it here, that's an easy fix. Something more complex, but if they have a history of peptic ulcer disease, you want to ask them if they're vomiting, what their vomit looks like, if they're having stools and what that looks like, and if this leads you down to the road where you're suspecting a GI bleed, hopefully in this case a stable GI bleed, right, then you're going to want to start IV Protonix, and then endoscopy is going to be your answer. And if it's an unstable GI bleed, there's going to be some resuscitation in there as well, and things are going to be happening much more quickly. And depending on if it's a bariatric patient or who the attending is, you may be calling GI. But before that, you can call your senior and sort those sorts of things out. Especially if the patient is unstable, you'll be calling your senior, of course, and talking it out with them too. So you're never alone in any of these scenarios. So switching gears again, if you go and see the patient, order troponins, they come back elevated, no reason to think they have demand ischemia, and you think it's really acute coronary syndrome, you're of course going to want to trend the troponins, and you're going to want to talk to cardiology. Treatment for ACS is that old acronym MONA for morphine, oxygen, nitrates, aspirin. And per cardiology, doing either a heparin drip versus taking them to the cath lab. So another scenario, if you've worked up your patient for chest pain, gotten an EKG, and you find new onset atrial fibrillation, hopefully you listened to their heart beforehand, and you maybe already heard it or felt their pulse and heard it. Then, if this is new onset, you're going to want to let cardiology know. And usually what they'll say to do if the patient is stable is to bolus with diltiazem and then start a diltiazem drip. If you're in the scenario where their blood pressure cannot tolerate diltiazem and they're hypotensive, then the drug of choice is amiodarone. But that's something the cardiology team will be in charge of course, and they're going to want to think, give it a few thoughts before starting amiodarone, because once you start them on that, then they have to be on it for at least a month, and there are a lot of side effects, so it's going to affect their PFTs, TFTs, and LFTs, so lungs, thyroid, liver, amongst other things. So that's absolutely cardiology's call. And then if they're unstable, then you're going to be working with the medical code team and maybe cardioverting if necessary. If you get an EKG, you see atrial fibrillation, and the patient has a known history of AFib, then you're going to want to make sure their home meds are restarted. And usually that's going to be with a beta blocker or calcium channel blocker, and keeping in mind that they can stay in AFib as long as they're stable and their heart rate is good. If you have a patient with chest pain and you get an EKG and then you look and you see SVT, the first thing you can do if they're stable enough, then you can try carotid massage. That's the most common of the three of these listed here that you'll do for vagal maneuvers, and that can really work. And then if they're unstable, you're going to be using IV adenosine, especially if a quick carotid massage doesn't work, and you're going to be wanting to call cardiology about that if you're using IV adenosine. If you go and assess a patient and you realize that their chest pain is secondary to oxygenation issues, you're going to want to, of course, assess the situation, look at their SATs, make sure that they're on continuous pulse ox. Usually they will be, but it's something you need to know. Look at the chest x-ray or order a chest x-ray if there isn't already one ordered. And then decide if you want to get an ABG if you're really concerned about their oxygenation status. So when it comes to patients with poor oxygenation, there are three directions we can go. The first direction is that we can escalate care in terms of giving them oxygen with nasal cannula, incentive spirometry. If that doesn't work, you can do BiPAP. If that doesn't work, you intubate. Put them on the vent. Another direction you can go is if they're fluid overloaded. So the second way you can deal with poor oxygenation is via diuresis. The third way is if you have a patient with COPD or asthma, reactive airway disease. In that scenario, they can respond well to breathing treatments. So there are kind of three ways this can go. The way that you're going to care about most is going to be if you need to go all the way up to intubation, because you need to be prepared and in the room and ready. So you're going to want to make sure respiratory is in the room. The respiratory team is oftentimes going to have most of these things ready for you, but you don't want to take that for granted, and you want to make sure you have all your ducks in a row. So with the respiratory team usually comes the vent. You want to make sure that they have capnography so you can confirm color change once you're intubated. You want to make sure that the suction is ready to go and on. You want to make sure you have your ET tube and choose your size. And then you're going to want to make sure that you have the gyroscope in the room, whether or not you're using a MAC. You still need to have the gyroscope in the room. And you want to have a bolusable fluid in case the patient becomes hypotensive, so normal saline or LR. And then it's very helpful to have pharmacy in the room. So you're going to want to use paralytics and sedatives, usually 20 of etomidate and 100 of sux. You're going the other route, the route of a COPD or an asthma patient. You can use BiPAP on these patients too if need be. Or you can use DuoNeb, Xopenex, saline nebs if the issue is more that they're needing a breathing treatment. Xopenex is nice because it doesn't increase the heart rate as much. Sorry. And you also can use home inhalers. Make sure that those are restarted. If you go and see a patient and upon physical exam you notice decreased breath sounds, chest x-ray, you see a pneumothorax, treatment for that is placing a chest tube. Using a lot of lidocaine and maybe some Dilaudid. Not necessarily conscious sedation, but usually Dilaudid does it, maybe Versed. Like I said, lots of lidocaine. And then, of course, don't forget to order your post-procedure chest x-ray to confirm placement. If you go and see a patient and you are concerned about a PE, this is one of the things, of course, that can kill a patient, so this is really important. And questions you're going to want to be asking as you're considering a PE is, have they been on DVT prophylaxis, and what has that prophylaxis been? Is there a sign of DVT? Are we measuring leg circumference? And then if you have a strong suspicion, the way to look for that PE is, of course, the CTA of the chest. So before I order a CTA of the chest, that's something to talk over with both your senior and the attending. And then based on findings, you may end up starting a heparin drip. Now, importantly, if the patient has a massive PE and is, in this case, going to be unstable, most likely, they're going to have, if they have evidence of right heart strain or are unstable, they may need thrombolytics or intervention. Pull that clot out. So it's a very serious deal. Switching gears again, if you have a patient, you go see them, you get a chest x-ray, probably a CBC already, and you find that they have pneumonia, you will want to make sure you have sputum cultures ordered, blood cultures ordered, and then start them on IV antibiotics. So these are the empiric treatments before you have those cultures back. For community-acquired pneumonia, it's IV ceftriaxone and azithromycin, or levofloxacin, and for hospital-acquired, it's Zosyn, Levo, and Vanc. So, in summary, we want to rule out things that can kill people, make sure our patients are safe, keeping in mind we're convinced that they are safe, that common things are common, and then think critically before calling your senior and having a discussion about the patient. And then, if need be, you can ask cardiology for help, and if necessary, you can always call consults in the middle of the night. And if necessary, of course, you can always call attendings in the night as well. But in all these cases, you'll be talking to your senior first. So lots of room for communication and discussion. But just make sure that you're thinking critically and having all of these things in mind as you're getting these phone calls. So I will be seeing you all soon, and I look forward to working with you.